Myself, I'm Sakthivel from Medicine Core. I'm going to present Pulseless. So you see, a 70-year-old student from Jharkhand presented with complaints of incidentally detected to have blood pressure of 200/110 during a doctor visit in July 23 for a viral fever. For that evaluation only he came for. He had no history of any arthralgia, skin rashes or oral ulcers, no history of any fever, loss of weight or loss of appetite, no history of hypertension, hypertension or renal disease in the family, or no history of any sudden cardiac death in the family. First, he was admitted once with post-reversible encephalopathy syndrome and twice with pulmonary edema in the outside. Once a time, he's requiring for intubation also. On vitals, his pulse rate was 96 per minute. All peripheral pulse were felt equally. On forelimb BP, it showed right upper limb 200/100 mmHg, and left upper limb it was 190 per 90 mmHg, and right lower limb it was 180 per 90 mmHg, and left lower limb was 190 per 90, with no any renal, carotid, or subclavian root felt, and no pala lymphadenopathy, oral ulcers, skin rash, or elevated JVP, and systemic examination were unremarkable. So we initially considered as a 70-year-old presented as a young onset hypertension. For that we were evaluating. Initial differential we were considered was first was renal causes like polycystic kidney disease or chronic kidney disease, or renal artery stenosis, or glomerulonephritis. And second is endocrine causes, mainly primary hyperaldosteronism, pheochromocytoma, Cushing syndrome, hypothyroidism, and considered adrenal hyperplasia. And vascular causes, coarctation of aorta, vasculitis, large or medium muscle vasculitis, and genetic causes like Liddle syndrome. But here, so our initial evaluation showed HB of 10.3 with normocytic pneumochromic anemia, with LFT was normal. In renal, as creatinine was elevated to 2.21, with electrolytes of sodium was 137, potassium of 4.0, with bicarb of 21. In urine routine, it showed proteinuria of 2+, and her inflammatory markers ESR 41 with CRP was 10/3, it was mildly elevated, and the vascular workup anti-PR3 and M2 was negative, and ANA also negative, with thyroid was 2.4, which was normal, and we did echo, which showed left ventricular hypertrophy. So for that, we further went for a renal artery Doppler. In renal artery Doppler, it showed the slow TARDIS waveforms in the Doppler. It showed mainly a bilateral intrarenal artery stenosis. So we went for angiogram. From CT angio vertex to toes, it showed a 7 cm long segment of infrarenal abdominal aorta thickening associated with bilateral renal arteries. Bilateral renal arteries also stenosed. So our final diagnosis considered was Takayasu arteritis type 4 and resistant hypertension. Here mainly I want to talk about the resistant hypertension, because during the ward stay, patient blood pressure was we cannot able to maintain under 140. So I went to how to approach the resistant hypertension and how to manage it. So resistant hypertension, overall prevalence of hypertension in India stands as 29%. The definition of resistant hypertension is a failure to achieve a blood pressure of less than 138 mmHg, or average of BP of less than 125/75 in the ambulatory BP, 24-hour ambulatory BP monitoring, with use of triple drug therapy. The triple drug therapy includes the calcium channel blockers, ACE or ARB, or any other one group is one will be a diuretic. Third group will be the diuretics. So if you are labeling as a patient with apparent resistant hypertension, before that we need to exclude is there white coat hypertension is there or not, and another one is the patient is compliance to his medications or not. If that is all ruled out, we can present patient labeled as a true resistant hypertension. This Chavez 3 is mainly used in the OPD. If in the chronic hypertension patients in the OPD, patient will suddenly come and we check the BP will be shoot up. It's mainly due to the external and internal factors like environmental temperature or internal factors of patient emotional or so. This that time we cannot patient to treat as a resistant hypertension. So mainly for resistant hypertension is a stepwise approach of the antihypertensives. Another one is the renal denervation. So in stepwise approach, first the triple drug regimen we need to optimize the optimal dose or highest maximum doses. Then if that also not controlled, then we check the third group of diuretics, we can change the diuretics from hydrochlorothiazide, or we can change to chlorothalidone with the maximum doses. If that also not controlled, then we can go for mineralocorticoids like spironolactone. And after that also, if blood pressure was not controlled, we can add for fifth group of beta blockers. If after that also blood pressure was not controlling, last option is we have minoxidil groups. It is a randomized control trial released in 2020 in the lesson showed efficacy of catheter-based renal denervation in the absence of antihypertensive medications, such as prior hypertension trial, and it was a multi-center randomized sham control trial. So here in this study, this was the time, and this was the blood pressure. This was the baseline blood pressure, and after the denervation, after 3 months of follow-up, her blood pressure was decreased. In compared to the shams. In the shams procedure, they didn't do any interventions. In Takayasu arteritis, I only simply talk about classification of Takayasu arteritis.
What is the slide about? So what exactly the study showed?
So the study showed without any antihypertensives, we do the degeneration of the renal arteries. It will decrease the mean blood pressure maximum about to 40 to 60 mm.
Sure.
In nominous criteria for Takayasu arteritis, there is 5 classifications. In first one, only the aortic branches was involved. In type 2, ascending aorta with aortic branches was involved. Type 2A. In type 2B, ascending aorta, aortic branches, and descending aorta was involved. In type 3, descending aorta with thoracic aorta was involved with renal. In type 4, only abdominal aorta with renal arteries were involved, and fifth, ascending all over the aorta was involved. So in the ACR Euler criteria in 2021, it showed the criteria of absolute requirements was age was less than 60 with evidence of vasculitis and imaging. In additional criteria, patient will be female age and angina or ischemic cardiac pain, arm or leg calculation, and vascular bruit, reduced pulse in upper extremity, carotid artery abnormality, or systolic blood pressure in different more than 20 mm. In additional imaging, number of affected arterial arteries, if 1 or 2 or 3, are symmetric involvement of the paired arteries. In our patients, mainly involved as abdominal aorta with renal involvement, and age was less than 60 with vasculitis on imaging. In 2021, the ACR criteria management mainly was if patient present with active Takayasu arteritis, we can initially start with the high dose daily oral corticosteroids, and then we add with immunosuppressants agents. Followed that based on the clinical remission 3 to 6 months follow-up period, we can gradually taper the glucocorticoids and continue the immunosuppression therapy. If patient had the vascular changes identified on the imaging studies, so initially we'll increase the immunosuppressive initially itself. And if patient progressively worsening ischemia, we need to consider the surgical intervention. In our patient, patient inflammatory was very low, so we started with the low dose steroids, and he was persistently having resistant hypertension. We were planned for renovascular stenting in cardio. Lenic punch was resistant hypertension and renal denervation. Thank
you. So you send the patient for stenting, is it? Why not renal denervation? Your study showed significant result, is it? Why don't you apply it in your clinical practice? This is about how do you interpret evidence. So the question was, you saw that study, right? It showed very promising results. So why not go for it? If available, let us say everything is available, will you go for it? Say something.
We don't know if they included this cohort of patients with mechanical stimulus.
You have to look at a lot of things before you change your practice based on the evidence. So that's what I was asking. So what all things you look at in a study before you include the results changing your practice. So many things you have to see. So one thing is what cohort of the patients they had, whether that the study itself, how you evaluate any paper based on all the criterias. Here it will be mainly what is the internal validity of the study, whether you can extrapolate that results to your own population. Okay, so first whether the study was done well or not, and second is next is whether you can apply those results in your population. Did you consider? No. Sure. Okay.